Coming down to the academic part, this is the poster which we had presented at the ISMO Congress happened this year in Paris. We all have been using docetaxel since long time, and we all have faced toxicity because of docetaxel time and again. Docetaxel, nanosomal docetaxel lipid suspension, this formulation was used, developed using lipid excipients which were generally recognized as safe to overcome the toxicity challenges associated with solvents of polysorbate 80 and ethanol. And we all, if you remember, docetaxel, we began using docetaxel in the dose of 100 per meter square, especially in breast cancer. Later on, we reduced the dose to 75 per meter square because at 100 milligram per meter square, it causes significant toxicity and there is a risk of increased mortality. So this study was to assess the efficacy and safety of NDLS monotherapy in patients with locally advanced or metastatic non-resectable lung cancer who had failed one line of platinum-based chemotherapy. It was a randomized, multi-center, phase 4 open-label, 2-arm efficacy and safety study of NDLS in the said population, and it was for patients aged between 18 to 65 years with histologically or cytologically confirmed lung cancer. There were 2 treatment arms. One treatment arm was NDLS at a dose of 75 per meter square, 6 cycles every 3 weekly. And the other was 100 per meter square given every 3 weekly, same 6 cycles. And then the response assessment was done as per RECIST 1.1. The primary endpoint was overall response rate that was defined as CR plus PR. And secondary endpoint was disease control rate, best overall response, overall survival, and progression-free survival. And of course, the safety events were recorded. This was done like any other clinical trial. Though it was a phase 4 study, it was done in the complete spirit of a regular clinical trial. Of the 102 screened patients, 80 patients were randomized because 22 patients failed screening due to either non-fulfillment of inclusion-exclusion criteria or loss to follow-up, and some patients had withdrawn consent. 34 patients were there in the T1 arm and 26 patients in the T2 arm qualified for efficacy population. That is, patients who received at least more than one dose and have undergone more than one efficacy evaluation. Safety population, it was done for all comers. Baseline demographics was more or less comparable. Age, height, weight, everything was more or less similar in both the groups, except that there was a phenomenal male preponderance. Most of the patients were males compared to females. The 75 per meter square dose did not have any complete responders and a very small number of partial responders. Majority of the patients had a stable disease. 77% had stable disease. But as we escalated the dose to 100 per meter square, there were 15% patients who underwent a partial response and 69% patients had stable disease. So the overall response rate for T1 and T2 was as such. The DCR was 79% for T1 and 81% for 100 per meter square. The overall survival at 1 year, the median PFS in T1 and T2 arm was 8.7 and 8.13 months. So not much of a difference in the progression-free survival. The median OS was not reached at the time of analysis for presentation. Safety, as expected, docetaxel is not an easy drug, causes a lot of problems. Even otherwise, these patients were pre-treated with at least one dose of one line of platinum therapy. Patients had anemia, leukopenia, abdominal pain, diarrhea, vomiting, asthenia, usual side effects of docetaxel, and they were commonly reported. And none of these patients had hyperglycemia because we did not have to use steroids. There were no infusion-related reactions in spite of not using steroids, and no significant neuropathy. Majority of the patients had at least one adverse event. 87.2 and 90.2% patients in both the groups had at least one adverse event, and almost 20% of patients in both the arms had at least one serious adverse event. The toxicity, as I said, most of the hematologic and non-hematologic toxicity of docetaxel. Grade 1, grade 2 toxicity was quite common, but grade 3 and above toxicity in both the arms, of course the numbers are not very big, but in both the arms they had very small number of toxicities, and I don't remember any major concern for toxicity. So to conclude, NDLS monotherapy was effective and well tolerated in the treatment of advanced NSCLC. We could escalate the dose from 75 to 100 per meter square, and the efficacy also correspondingly increased from 75 to 100. Though there is a conventional docetaxel, there is a boxed warning that more than 100 per meter square dose is associated with increased mortality. Here, these patients tolerated 100 per meter square without any additional safety or tolerability concern. So this was our poster at ISMO. Thank you. Thank you, Ashay.